Hi, my name is Jaden Haig, and this is my presentation on perinatal mood and anxiety disorders. 1 in 7 pregnant and postpartum women are affected by perinatal mood and anxiety disorders. Perinatal mood and anxiety disorders are a spectrum of emotional complications. Perinatal or postpartum mood and anxiety disorders is the term used to describe distressing feelings that occur during pregnancy, the perinatal period, and throughout the first year after pregnancy, the postpartum period. Carrying a baby is a significant task in which the body undergoes an experience of numerous changes in pregnancy and postpartum. These changes are natural and expected. However, they can also be overwhelming to the new parents. Perinatal mood and anxiety disorders are mental health disorders experienced during pregnancy, after birth, through adoption, and infant loss. 50% of perinatal mood and anxiety disorders occur during pregnancy, and 80% of cases go undiagnosed or untreated due to stigma, lack of awareness, and scarcity of specialized treatment options. Along with the lack of resources and stigma, up to 40% of low-income women experience a perinatal mood and anxiety disorder as well. 60% of perinatal mood and anxiety disorder cases are women that have a pre-existing comorbid psychiatric disorder. There are several types of perinatal mood and anxiety disorders. These are postpartum depression, post-traumatic stress disorder or PTSD, baby blues, psychosis, postpartum anxiety, obsessive-compulsive disorder or OCD, and bipolar disorder. The most common being postpartum depression, postpartum anxiety, and baby blues. Studies show contrasts in each type of mood and anxiety disorder along with similarities. Baby blues are mild, transient conditions that occur during the first few days after childbirth and can last approximately 10 days. If symptoms such as mood swings, anxiety, persistent sadness, irritability, feeling overwhelmed, crying, reduced concentration, difficulty sleeping, and appetite problems occur, the woman may be experiencing baby blues. After these 10 days, if symptoms remain, it is categorized as postpartum depression that is self-limiting. Postpartum depression is often used as an umbrella term or interchangeably with perinatal mood and anxiety disorders. A woman with postpartum depression can present signs of reoccurrence for future childbirths. Throughout pregnancy, some women may experience anxiety. Anxiety in pregnancy differs from pregnancy worries by the intensity, persistence, and negative effects. Between 15 to 20% of women will experience moderate to severe symptoms of postpartum anxiety. Forms of anxiety women may experience are generalized anxiety disorder, OCD, or panic disorder. Postpartum acquired OCD is experienced as intrusive and unwanted recurrent and persistent thoughts, urges, or images. It can also be seen as repetitive behaviors or mental acts and lasts greater than 1 hour per day. PTSD in the postpartum period reflects back to traumatic birth experiences occurring only to those that may have experienced an event during their birthing process. Psychosis and bipolar disorder in the perinatal and postpartum period have low occurrence rates. Psychosis is seen as low as in 1 in 1,000 childbirths, and bipolar disorder is seen in 2 to 8% of cases. Perinatal mood and anxiety disorders are a group of conditions that can significantly impact a new parent's mental health. Common signs and symptoms of all types of perinatal mood and anxiety disorders include feelings of guilt or shame, anger, a lack of interest in the baby or difficulty bonding. Sleep and appetite disturbances often accompany crying, sadness, and a pervasive sense of hopelessness. Many individuals experience constant worrying or racing thoughts, which can escalate to thoughts of harming themselves or their baby. Physical symptoms such as hot flashes, dizziness, and nausea have also been reported. Additionally, a loss of interest, joy, or pleasure in previously enjoyed activities can signal the presence of a perinatal mood and anxiety disorder. Recognizing these symptoms early and seeking professional support is critical for recovery and promoting the well-being of both parent and child, as perinatal mood and anxiety disorders can have many impacts on the woman's health, the ability to connect with the infant, relationships with their partner or loved ones, and can have impacts on the infant's health and growth. The perinatal is one of the most vulnerable to women due to risk factors being associated with perinatal mood and anxiety disorders. Risk factors can be biological or sociological. Biological risk factors include hormonal fluctuations, a personal or family history of mental health conditions, substance use, complications during pregnancy or delivery, pregnancy resulting in multiple births, preterm birth, and low birth weight, and significant sleep deprivation. Sociological risk factors often include a lack of social support, financial or relationship stress, a history of trauma or abuse, and low socioeconomic status, a young age, immigration, an unplanned pregnancy, anxious personality styles, breastfeeding challenges, and unrealistic expectations about motherhood. Together, these factors can heighten vulnerability, making early identification and intervention crucial to prevent perinatal mood and anxiety disorders and support maternal well-being. The health disparities associated with perinatal mood and anxiety disorders are significant and varied in approach to healthcare. Women that are impacted by adverse childhood events and social determinants of health are at increased risk of developing perinatal mood and anxiety disorders. Social determinants of health associated with the PMADS are economic instability, language barriers, violence, access to healthcare, education, housing, job opportunities, food security, and exercise also aid in increased risk factors of developing a perinatal mood and anxiety disorder. Women in a lower socioeconomic status often have lower opportunities to gain access to healthcare, the higher education levels, and adequate support groups. Economically, costs can hinder care. Culture plays a central key in social determinants of health. Racial and ethnical disparities contribute to depression and anxiety among peripartum period. The racial disparities worsen by a lack of proximity, means of access to healthcare, a history of trauma, and previously diagnosis of depression. Early recognition leads to better outcomes and management of perinatal mood and anxiety disorders. Screening for perinatal mood and anxiety disorders can be identified through many methods. Depression and anxiety screening tools such as the Patient Health Questionnaire, the Edinburgh Postnatal Depression Scale, and the Perinatal Generalized Anxiety and Depression Disorder Scale provide insight to the intensity and type of disorder needing addressed. The Edinburgh Postnatal Depression Scale is a widely used tool. It is a questionnaire designed to assess the emotional well-being of postpartum individuals. The scale consists of 10 items evaluating symptoms such as sadness, anxiety, guilt, and coping abilities over the past week. Healthcare providers use this tool to screen for depression and anxiety in postpartum individuals, ensuring rapid recognition of those at risk. With better management and outcomes, there is a direct correlation to promote health and well-being of pregnant and postpartum women and their children. Screening should not solely be reliable on instruments, assessment data, coping strategies in pregnancy and postpartum, and presence of significant support. The implementation of routine screenings ensures opportunities to provide beneficial interventions. The treatment of perinatal mood and anxiety disorders often includes the use of selective serotonin reuptake inhibitors, or SSRIs, as they are the first line of treatment for perinatal mood and anxiety disorders, which are effective in alleviating symptoms of depression and anxiety. Commonly prescribed SSRIs include Celexa, Lexapro, Prozac, Pavlix, and Zoloft. These medications work by increasing serotonin levels in the brain, helping to stabilize mood and reduce the emotional distress associated with PMADS. Recent advancements have led to the approval of new medications specifically for postpartum depression. Brexanolone, the first FDA-approved medication for postpartum depression, is administered intravenously over 60 hours. Zuranolone has been introduced as an oral medication, offering a convenient alternative for managing postpartum depression. These new options ensure a more comprehensive and personalized approach to managing PMADS, improving outcomes for mothers and their families. Other non-pharmacological treatment options are counseling, exercise, bright light therapy, yoga, adequate sleep, healthy dieting, support groups, and relaxation techniques. Another avenue to explore is to consider the father's or support person. The father or support person may be prone to vulnerability or experience a void for paternal mental health support. Maternal PMADS are more openly discussed than paternal, leaving a higher percentage of men that experience perinatal depression. Addressing paternal PMADS can identify and benefit the family well-being and improve the family unit. Barriers to seeking help for emotional stress in the postpartum period are substantial. Barriers can prevent individuals from seeking care or support they need. Barriers can include a lack of knowledge, fear of failing, stigma, denial, emotions, appearance of coping with motherhood demands, unrealistic thoughts or expectations. A lack of knowledge about the symptoms and treatment options often leaves parents unaware that what they are experiencing is not uncommon and is treatable. Fear of failing as a parent with added stigma and societal judgment may discourage individuals from admitting they are struggling. Denial of their symptoms, along with overwhelming emotions, can also decrease efforts to seek help. Additionally, the pressure to appear as though they are coping with the demands of motherhood while experiencing unrealistic thoughts and expectations about parenthood can create isolation and shame. These barriers emphasize the importance of raising awareness, reducing stigma, and fostering a supportive environment for new parents to seek care. Linked on this slide is a QR code for more educational material about perinatal mood and anxiety disorders. Thank you.